This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
So I'm really happy to be here tonight to talk with you about what I think is a very important issue. These are the variety of different diseases that can affect the cardiovascular system. Coronary artery disease is what I'll focus on for most of my talk tonight. But obviously you can have many other malformations or diseases of the heart, including valvular heart disease, congestive heart failure, which is really the largest problem. 5 million people in the United States suffer from congestive heart failure, with about 500,000 new cases a year. And it's one of the initiatives in the Institute, a grand challenge, as we say, that we're going to try to solve for patients with congestive heart failure. Aortic disease with aneurysms, irregular heartbeats, congenital heart disease, and stroke are the major issues. So why is this important to focus on women's cardiovascular health? Well, as is alluded to earlier, it's the #1 killer of women. The majority of American women really don't have any great awareness about this problem. And then finally, women are often the decision makers in the family. So these next few slides will tell you 10 things that every woman should know about heart disease. First is that cardiovascular disease is the #1 cause of death in women. Each year, heart disease kills more women than men. 38% of women will die within 1 year of suffering a heart attack, and that's compared to only about 25% of men. And this graph just shows you the number of deaths over the past 2 decades. And you can see that about 20 years ago, the trend changed, where now women clearly outnumber men in the number of cardiovascular deaths. This, I think, is surprising to many physicians. Also, that heart disease affects many more women than breast cancer. The myth is that breast cancer is the greatest risk to American women. However, heart disease kills more women than the next 7 causes of death combined, including breast cancer. Only 8% of women consider cardiovascular disease their greatest health risk, yet nearly 1 in 2 will die of heart disease, where only 1 in 33 will die from breast cancer. This just shows a graph indicating that over 40% of the diseases that kill women are cardiovascular, compared to only 22% of cancer death. This is a survey that was done asking women what they feared most in terms of their health. And as you can see, most feared the health risk associated with cancer, whereas the number of deaths is half the number of heart disease, and less than 10% of women listed heart disease as their biggest fear of death. This just tells you what a heart attack is. A heart attack simply is when the heart muscle that pumps blood out to the rest of the body does not get enough blood flow, enough nutrients, enough oxygen to sustain that function. And it's due to a blockage of the coronary artery. The coronary arteries are the arteries that take the blood flow to the heart muscle, and when the coronary artery occludes, then blood flow can't get beyond the occlusion and the heart muscle will die. The third thing is that risk factors help to predict who is at risk to develop coronary artery disease. Obviously, family history. If you have a strong family history of heart disease in your family, then you're certainly at a higher risk of developing coronary artery disease in particular. And obviously, as we all grow older, the chance of developing heart disease increases. And then obviously there's a difference not only in gender but also in race, and African American women are at much higher risk of developing death from coronary artery disease than other segments of the population. This is obvious. I don't think anybody in the room probably smokes, but if you do, you need to stop, because this is one of the things that you can control, you can modify, and certainly if you stop smoking, the risk for heart disease, particularly coronary artery disease, is reduced. Importantly, secondhand smoke also increases risk, and there are several studies that confirm that. Now, cholesterol. There are certainly good cholesterol and bad cholesterol. The good cholesterol is the HDL. Low levels of HDL, particularly when you get under 40, is a concern. So you need to consult with your physician and get blood drawn so that you can measure not only your overall cholesterol, but the fractions such as HDL, LDL, and your triglyceride levels. And there are many other things in your blood that can be measured and can be modified to decrease risk. Obesity, as a nation, this is a major risk. The usual guideline is if you're more than 30 pounds over your ideal body weight, and there are nomograms that you can find, your doctor can tell you, but obviously most of you know that if you're overweight, you certainly increase your risk of heart disease. This was not always known. It used to be thought that obesity did not play a factor in the risk for coronary artery disease, but it obviously does. And then physical activity. We know that exercise can lower your LDL, the bad cholesterol, and increase your HDL. And simply walking vigorously for about 30 minutes a couple of times a week is all you need. And this is a modifiable risk that you can introduce into your healthy lifestyle. Other factors that are fairly obvious: blood pressure. More than half of women over 55 will have high blood pressure. In my experience, people are not very compliant about taking antihypertensive medications. But I would encourage you to check your blood pressure, monitor it, and if you have any increased blood pressure, consult with your physician. Diet, again, can help you with blood pressure. A diet that's lower in sodium is obviously better for you. And then diabetes. I think everyone would know that diabetes increases your risk about 3 to 7-fold for having coronary artery disease. Women's experience with coronary artery disease is definitely different than men. Women are more likely to die within the first year after a heart attack. They're less likely to survive from coronary artery bypass surgery. And they're more likely to have complications following angioplasty. And this is oftentimes related to the fact that when you do a coronary artery bypass, and I'll show you a drawing of that later, the artery that you're bypassing into is generally smaller in women because their hearts are smaller. And also that women are more likely to die from an arrhythmic death in addition to coronary artery disease. So this is important. I'm sure that most of you have a good idea of what the warning signs of a heart attack are, but we'll just go over them. Discomfort of your chest, jaw, neck, back, shoulder, arm, shortness of breath, sense of nausea, sweating, fatigue, weakness, and feelings of anxiety. And the most important thing is that women's symptoms are often vague and easily overlooked. And this is quite different to men who typically have a heavy chest pressure or bad chest pain and often seek medical advice sooner because the symptoms are not as dramatic in women, and because men are so much more dramatic in their lack of being able to tolerate pain and whine about it, they get to the doctor sooner. But this is why I think that you need to be aware that the symptoms of a heart attack can be very subtle in women. Warning signs of a stroke: weakness or numbness in the face or arm, confusion, difficulty in speaking, loss of vision can often be a harbinger of a small stroke or an emboli going to your retinal artery. Dizziness or severe headache. So these are also symptoms that you should seek medical attention for. Just a word about some of the common tests that can be used to help and diagnose heart disease. All of these tests here are non-invasive tests. Certainly the lipid profile, HDL and LDL, are blood tests that can be drawn, electrocardiograms, a stress test. A simple electrocardiogram may not tell you about the risk for heart disease, but if you have a stress echocardiogram or a stress EKG, that can produce more need for oxygen to your heart muscle. And if your coronary arteries have disease and are narrowed, then as you put more demand on your heart, then you're more likely to have changes in the function of the heart muscle wall, which can be seen by echocardiogram, or a change in your EKG. Your physician would then refer you for an invasive cardiac catheterization, where we actually put catheters into your coronary arteries and take pictures of the arteries. This is a really big problem. Most all of the drug trials, many of the coronary artery bypass trials, many of the medical device trials are all done on 50-year-old white men. This is a major issue in prospective randomized trials. Women are different than men, particularly in these trials, and there needs to be more awareness even into the design of clinical trials. There needs to be more in the way of including women as representative. If you get to the point where you discover that you have heart disease, particularly coronary artery disease, there are excellent medications that can be tried. If the medications fail and you still have symptoms or risk, balloon angioplasty, bypass surgery, and certainly pacemakers and defibrillators. This is a coronary artery stent. Remember I showed you the picture. If you have an occluded coronary artery, you have a heart attack. But the idea is to diagnose this disease before the heart attack occurs so that we can intervene. This is a stent that's placed in one of these blockages, narrowings in the artery, opened up with a balloon. And this particular new generation of stent actually elutes drug that keeps the stent from having scar tissue buildup and narrowing occur, which has been a problem with some of the earlier generation of stents. This is a coronary angiogram with the left main coronary artery and the left-sided branches. I think you can see that there's a very tight narrowing there that's really not amenable to having a stent placed. A stent can be placed while you're awake in the cardiac catheterization lab with one stick in the artery to your leg, and you go home that day or the next day. Coronary artery bypass surgery is needed when the stents and medications fail. This can be done in a variety of ways using the artery under the breastbone called the left internal mammary artery. We can use artery from your arm, the radial artery, or vein from your leg. This is essentially what the operation that President Clinton had. We try to use more arterial grafts than vein grafts. This is sort of a summary of the things that we've been over. Know your risk factors, stop smoking, maintain a healthy body weight, eat a diet low in saturated fats, monitor your blood pressure, check to see if you have diabetes. Certainly if you have a family history of diabetes, keep that in mind. Exercise regularly, limit alcohol intake, although, you know, we can talk about red wine and the benefits of that. Learn stress management skills. Maintain social relationships. The last thing is know the warning signs of a heart attack and really remember that they can be very subtle. So if someone you know has risk factors for heart disease, try to get them to a doctor, try to get on top of this, and really, if you think you're having symptoms that we've gone over of a heart attack or stroke, call 911 and learn CPR, because you never know, it might be a man's life that you save.
What I'm going to really give you is a little story about hormones, and I can tell you that 5 years ago, if Bobby had given this talk, we would be hearing every woman should be taking hormones. That was really the #1 thing that doctors were telling women, and the Women's Health Initiative really reversed that. Now, one thing, you've already heard a lot of statistics, so I would like to just quickly go over a couple highlights. When we look at the #1 cause of death in women, it's heart disease, so this is all women. The next big one to pop out here is stroke. Now, all cancers put together exceed stroke, but no one cancer exceeds stroke. Stroke kills more women than lung cancer, it kills more women than breast cancer, it kills more women than colon cancer, so cardiovascular diseases are really important. Now, that said, I also want to jump over here and point out that the vast majority of women who are dying of heart disease are 80 years old and over. And in fact, half of women now are living past 80. So that's the good news. We heard a lot about dying, and I think it's important to get back to the fact that that's inevitable. We are going to die someday. But what we want to do is prevent this from happening prematurely, and we certainly want to live as long as we can, as healthy as we can. So we really should be talking about cardiovascular health rather than disease. What I want to do now is jump into my story about hormones and point out that when we talk about postmenopausal hormones, this is something that's been part of our culture for more than 60 years. The FDA approved hormones for menopausal management in 1942. So it's been with us. We've seen it almost like taking aspirin. We never really considered it a serious issue. Now, these are the prescriptions of estrogen in millions going up. There's a big drop here because in 1975, the New England Journal of Medicine published 2 articles that said that women who had a uterus who were taking estrogen got a dramatic increase in uterine cancer. And we are a cancer-phobic country, well, world, and that scared a lot of women, and they stopped. The endocrinologist basically jumped in and said, well, if we added progestin to it, we could protect the uterus from this cancer. And from that point on, any woman with a uterus was given estrogen and progestin. But all of the data that we were gathering from observational studies was based still primarily on estrogen only. So one big mistake that got made early on was that we started assuming that everything about estrogen applied to estrogen and progestin. And they're really very different issues. Now that said, I'll point out that the idea that estrogen prevented heart disease actually first came out in about 1985. There was a little bit of evidence before that. But in 1985, the New England Journal of Medicine published 2 articles back to back, one from the famous Framingham study, and that's this one over here, and one from the Nurses' Health Study. Now, if you're not used to reading these kinds of slides, let me just point out that relative risk, if something fell right on that line, it would mean that this drug had no effect at all. It was completely neutral. If it falls over here, it means that you've increased your risk of something going wrong, so that's bad. And if it falls over here, you've decreased your risk. Now, what you'll see is that the Framingham study and the Nurses' Health Study came out with exactly opposite outcomes. So in 1985, it came right out of the gate as a big controversy. Was Framingham right? Was the Nurses' Health Study right? And there's a very interesting story that I don't have time to tell about how it kind of was decided, but basically little bits of evidence that really weren't very strong started getting into the point where people began to believe, and then publication bias, all kinds of things reinforced the concept that estrogen prevented heart disease. And Framingham was kind of cast aside, and we didn't hear about it again until the big controversy 2 years ago. But one thing that we had to recognize is that observational studies, where you just follow a lot of people who have self-selected to take a drug, are very biased. And in the case of hormones, they were biased in a way that really gave us a different picture about the relationship of hormones and heart disease, because the hormone users as a group were more health conscious. As a group, they had better lifestyles. They were less obese, more physically active, less likely to smoke. They had good diets. They went to their doctors, and they were getting care for their cholesterol levels, their blood pressure. They were also getting mammograms, which is one reason why people started to think maybe that's why we see more breast cancer in women on hormones. It might be detection bias. They're finding out about it. But the big problem was all of these factors could result in lower heart disease without them taking one estrogen pill. And the other problem was all the literature was based on estrogen only, but most women have a uterus, and therefore most women were taking estrogen and progestin. What do we have in the story of estrogen and progestin? Really nothing until 1996, the Nurses' Health Study published it for the first time. So less than 10 years ago, we had anything coming out telling us that estrogen and progestin might also be associated with benefit. So those of us with a uterus were being treated as if we had had a hysterectomy. Now, you've already seen these risk factors, so I'll just quickly point out that people have been quite intrigued by the sex difference in the age that we start to talk about risk. For men, it's 45. For women, it's 55. People were saying, well, that's because of estrogen. Women are protected. But we didn't really have anything to prove that. You've already heard about high HDL being bad and low HDL being bad. We do actually separate them a little bit for men and women. Less than 40 is where we really start to worry about men. Less than 50, we start to worry about women, because we do have about 10 milligrams per deciliter difference. You've heard about high blood pressure and you've heard about family history, so I just want to move on and say that the first thing that the NIH decided to study was risk factors. It didn't have the money to look at heart disease. And so the first trial that came out to look at this question was called the PEPI study. And Stanford did that. I was one of the investigators for the PEPI study. There were 7 clinical centers. It was a very complex study in that we wanted to look at estrogen with and without progestin. We wanted to look at different ways of taking progestin. We wanted to look at different progestins. It was a complex study. But the bottom line was that it did show that estrogen increased HDL cholesterol, as was shown in a previous slide, and it decreased LDL cholesterol. And people jumped the gun and said that because of those changes, it's beneficial for heart disease. And something that we have to understand is just having a risk factor go up and down doesn't really tell us whether we're going to get heart disease or not. And that's what the big lesson is that we can't just look at risk factors anymore. We have to look at the outcomes. Now, what people focused on a lot was this was the evidence, and it got promoted in a big way. After the PEPI study came out, there was a lot more press about women should be taking estrogen. In fact, the American College of Cardiologists said any woman who had a heart attack should be put on estrogen. And they kind of ignored the fact that there were some bad outcomes in PEPI. Triglycerides, the fats in the blood, went up. Kind of a more recent risk factor called C-reactive protein went up. And obviously for women with a uterus, just estrogen alone was a bad thing. But at any rate, PEPI kind of launched this idea that, yes, everyone should be on it. And people started focusing on all older women should be on it too. And it jumped away from being a menopausal treatment, hormones being menopausal, and being something that was preventing heart disease. And then preventing all kinds of diseases of aging. We started having women taking it to prevent Alzheimer's disease. But we had no good data that any of these things were true. We just had a whole clinical practice being based on standard of care, put women on hormones. And so it was clear that we needed to get some clinical trial data. Now, the first big trial that came out looking at hard outcomes was called the HERS study. This was a study of women with heart disease, and it's also one that we did here at Stanford. There were 20 centers across the country that did the HERS study. It had 2,763 women with documented heart disease, very high risk for another heart attack. And they were randomly assigned to estrogen and progestin or to placebo. Now, again, I mentioned the American College of Cardiology had already said any woman with heart disease should be put on hormones. That came out a year before the study came out. What we actually saw in the HERS study was that, yes, HDL went up and LDL went down and triglycerides went up, but heart disease was completely neutral after 4 years. That said, in the first year of HERS, there were more heart attacks. So here were women going on these hormones to prevent heart disease, and they were actually precipitating a heart attack. So that what you see here is over time, in red, the estrogen and progestin group started out with more heart attacks than the placebo group in yellow. Now, a very interesting spin got played at the end, where we actually have, this is the number of women that were finishing each part of this study. So you see by 4 years, only half of the women made it to that 4-year point because the study, just the way the study was running, and a very small number made it to 5 years. But a lot of press was played on the fact that it looked like it reversed and maybe there was a long-term benefit. And so they actually spun it and got probably 2 more years out of hormone sales as a consequence. But when they actually looked at the study over the full time period, the big danger was in the first year, significantly more heart attacks for a woman with heart disease in the beginning going on hormones. And slowly over time, these averaged out, so there was no benefit after 7 years of these hormones. At this point, everyone agreed, okay, if you've had a heart attack, don't go on hormones. But what about a woman who's never had a heart attack? What about this primary prevention focus? And this was the Women's Health Initiative, which was conducted at 40 clinical centers, including Stanford. And this study actually, just so you know, has a huge diet trial underway. And we haven't published that yet because that trial's still going. We'll have that for you next year about this time. The hormone trial, however, has made a lot of press, and so I'm going to focus on the hormone trial. It had a specific goal, and that was to test whether all of our beliefs about hormones were true or false. Do these hormones, estrogen or estrogen and progestin, really prevent heart disease? Do they cause breast cancer? Do they prevent osteoporosis? All the data was on bone density. We didn't have any real fracture data. And if you looked at the whole picture, a woman isn't just a heart or a bone or a breast, she's this whole thing. Is she better off or not? And so that was what it was all about. Now, we had a data safety monitoring board that was instructed to monitor some very specific outcomes and build them into an algorithm as to what was the point where we should say this study has already gone far enough, we know the story. So there were 3 cardiovascular outcomes, heart attacks, strokes, and blood clots in the lungs, 3 cancer outcomes, at least for the women with a uterus, obviously the endometrial cancer didn't count if you had a hysterectomy, fractures, deaths, and then this global picture putting it all together. And the hypothesis that we went into was that heart disease was going to be so benefited that most likely we'd have to stop the study because women should be on hormones. That's really what was driving this study. And there was concern about breast cancer and concern about blood clots, expectation of benefit for bone. We really didn't know about stroke. We really didn't know about colon cancer. Now, the study was set up that if a woman had a hysterectomy, then she would be randomly assigned to either taking estrogen only in the form of Premarin or placebo. And if she still had her uterus, she would be getting estrogen and progestin in the form of Prempro or placebo. Now, that means we didn't study every estrogen, so many of you may be on a different estrogen, but we studied what 85% of women in the country were taking. And so we had 2 trials focusing on heart disease, but these cancers. I will mention that we also had a special memory study going on, and I'll say something about that at the end. But the big surprise was that, contrary to what the whole country had grown to believe, instead of seeing benefit, we had to stop one arm of this study, the estrogen and progestin arm, 3.5 years early because it turned out that the risks exceeded the benefits. But we kept the estrogen study going. So first I just want to say what happened with the estrogen and progestin study. And if you don't remember this, this was a huge story, and it was in the front of all the magazines. This is the one reason why anyone knows who I am, is because this study was so big, and it wasn't because of me. But what happened was, first of all, the flag went up that breast cancer was increased by 26%. We did have benefit to fractures, so that was the first proof that estrogen and progestin actually prevented fractures, and there were fewer colorectal cancers. But what really stopped the study wasn't the breast cancer. What stopped it was the fact that all the things that we expected to be benefits had loaded up on the side of risk. There were more heart attacks, there were more strokes, and there were these blood clots in the lungs, as well as in the legs. So it turned out that a drug that we had been pushing on women to prevent heart disease was actually increasing their risk. I won't go through all of this except to say that when you stack up all the risks and benefits, first of all, I'll point out that in yellow you see placebo. Women not on hormones do get heart attacks, they do get strokes. We need to reduce risk factors. If you go on hormones, you just increase your risk above and beyond what you already had. So we still need to focus on many other issues. Now, many people said, well, this was because the women were too old in that study, and they already had heart disease. And this slide is just to show you the difference between the WHI cohort, which predominantly had no heart disease starting in the study, compared to our HERS cohort, which were women with established heart disease. And if you just look at the green group, these are the placebo women in the Women's Health Initiative, so women who didn't have heart disease at the beginning of this 3-year period, versus women who did. This is showing you that the risk of having another heart attack, if you've already had one, is very high compared to the risk of having one if you haven't. But in both groups, the yellow line shows that adding estrogen and progestin increases that risk above and beyond what you already have. I'll also quickly point out that in the Women's Health Initiative, we saw that the greatest risk happens in the first year. So it's the first year of starting the hormones that really makes the big difference between being on hormones and not. Now, I'll just quickly point out that we didn't hear a lot of press this last February and March when the other arm of the trial was stopped, also prematurely and also for harm, and that was the estrogen-only arm. So this was the women with a hysterectomy who were on only estrogen, and this was stopped because of stroke. And what we learned from that is that there's actually an increased risk of stroke in both estrogen and progestin and estrogen only. There was not a difference in heart attacks with estrogen only. There was not a difference in breast cancer. In fact, if anything, it looked like there were fewer breast cancers. There was a benefit to hip fracture. So it's not as gloomy a picture as estrogen and progestin, but it's still in the direction of this is not something we should be promoting. It's something that really is about menopause and not about heart disease. So again, when you stack this up, you don't get a picture of every woman should be on hormones. So I will make again the point that the 2 trials came out with somewhat different results, suggesting either that women with a uterus and women with a hysterectomy are different groups, or that estrogen and progestin is different from estrogen, but both studies are clear that it's not what women should be doing. And last but not least on this story, I'll make the point that many women said to us, well, I don't want to stop my hormones. I'm worried about Alzheimer's disease. I heard that estrogen would prevent me from getting Alzheimer's disease. And what you see is that this is the estrogen and progestin study. Twice as many women developed dementia on estrogen and progestin as on placebo. So again, a very big myth that was shattered, and the estrogen-only study supported that for estrogen only as well. So I'll just jump to the point on menopausal hormones and say they are very effective for dealing with menopause, and that's what they're for. And the labeling has been changed such that we're very clear. The reasons you take estrogen and progestin is to deal with hot flushes and night sweats, and to deal with vaginal dryness and problems that relate to changes in the secretions. If that's your only problem, we recommend topical, not oral. There is a value in preventing osteoporosis, but we really recommend that women try other things first before they jump to that one. So it's definitely not about heart disease, it's about menopause, and it still makes sense for younger women who are at much lower risk for heart disease and for Alzheimer's. So coming back, when we look at this overall picture, heart disease really is primarily in older women, but it's still a major, major factor for younger women as well. You need to know your risks at all of these ages. And smoking, we've already mentioned. If you've had a heart attack, that's clearly a bad thing. Diabetes, he mentioned. Now, there's one point that didn't come up in the previous talk, and I want to say that now we have something that's called a CHD equivalent. So this is considered equal to having had a heart attack. Diabetes now falls in that category. So if a woman has diabetes, you basically need to be more aggressive in managing your LDL cholesterol and your weight and your physical activity and other things. Similarly, if you have something called metabolic syndrome, now these are the numbers for women. I'll quickly point out that there also is a metabolic syndrome equivalent for men. If you have 3 of any of those 5 factors on this table, then that's considered metabolic syndrome, and that's considered equal to having had a heart attack in terms of how aggressive and serious you need to be about your risk. So abdominal obesity in a woman, it's having a waist of 35 inches or greater. For men, it's a waist of 40 inches or greater. Fasting glucose is the same. This is below the level called diabetes, which is 126. So you need to start to be a little worried if it's even elevated. Low HDL cholesterol for women, this is less than 50. For men, it's less than 40. Triglycerides of 150 or greater for men and women, and blood pressure of 130/85 or greater for men and women. Now, that's below the level of being hypertensive, but if you have 3 of those 5, you need to be a lot more serious about your risk, and you certainly should be thinking about treatment. The other big thing I'm just going to quickly say is, what should a woman do about heart disease? What is the way to prevent it? And I'm a big proponent of diet, exercise, and weight control. I do want to point out that we now have very good data that lifestyle, diet, and exercise can actually prevent a person with high glucose levels from advancing to diabetes. A very big study came out 2 years ago demonstrating the value of diet and exercise and weight loss to prevent diabetes. So that's step 1. There's a huge study underway now looking at whether diabetics will actually prevent heart disease by doing diet and exercise. Now, it was mentioned that where you distribute your fat is important. In both men and women, we talk about a bad way of having your fat. So this is the so-called apple, and a good way, the so-called pear. There aren't very many pear men around, men with nice big thighs. But we do have a lot of men that have what we call android obesity. A woman who's carrying her fat this way has a much higher risk of diabetes, hypertension, bad cholesterol, and heart disease than a woman who's carrying it this way. So if you happen to have those nice thin legs that look great in dresses, you shouldn't feel as excited as those of us who have the big thighs and feel bad about it, because we're actually a little more protected. And you need to be a lot more concerned about your weight if you're carrying it in this metabolically dangerous way. And so last but not least, I want to make the point that if you do have excess weight, The recommendation is diet and exercise and behavioral therapy. When we talk about exercise, we use the 30 minutes of moderate intensity activity per day, at least 5 days a week. I will point out that the American College of Sports Medicine recommends even more exercise, especially for weight loss. And it also focuses on having some resistance work so that you maintain your lean body mass to preserve the lean mass, which is important as well. So with that, I'm just going to make the final point that to achieve optimal health for a woman, and this isn't just heart disease, it's true for cancers, it's true for a number of other issues, be physically active. I think that's probably more important than anything that we've talked about. Maintain a healthy weight. We do promote vegetables and fruits. The DASH study showed very nicely that eating more vegetables and fruits really decreases your blood pressure, so it's something that can be really as effective as a lot of blood pressure medications, so we promote that, and restrict saturated fat. Limit alcohol. We always say that, but we always talk about the red wine as well. And I want to make the final point is that menopausal hormones are not the way to prevent diseases of aging. It's really just about menopause. Thank you. The question was, once you've done an earth-shaking study, how long does it take for the medical community to jump on board? And this is a little bit of a facetious answer, but it depends on what kind of physician you're talking about and what kind of earth-shaking stories. So there are certain medical professions that didn't like this information at all, and a group of them have been fighting it vigorously. But by and large, internists, cardiologists adopted it immediately and moved on. Now, the good news for cardiology is that they have statins now, and this is the new drug on the market that works for men and women, so it's getting kind of the same press that estrogen used to, but it actually has a lot of good clinical trial data to support it, which the estrogen didn't. So I would say that the other answer to your question is it depends on how big a splash it actually makes. The media is very important in getting that information out because it turns out that you have a lot more to do with telling your doctors, I've heard this and I don't believe it anymore. There's a tremendous influence of the community on medical practice. And so in the case of the estrogen and progestin story, that was spread through within a month or two. The estrogen-only study, most people have never even heard of it, because the media didn't do anything about it. So lots of women say to me, I've been waiting for the estrogen study to come out, and it came out back in March.
I just had a comment about that. You know, it's fairly well proven that after you have a heart attack, you should probably be on a beta blocker. The American Heart Association is really concerned because in the United States, it's really only about 50, at most 70% of people that have heart attacks are on beta blockers. You know, there's some resistance to patients to taking beta blockers, but that's a very good point, that just because it's been proven and well studied, it doesn't mean it's adapted. And so that's why I think it's better. The internet's here. These kind of things are here to inform people, to challenge your doctors.
Challenge them or inform them, educate them. But doctors are doing a lot of education of people as well, and that's an important thing. But it's true, there's a lot of drugs that should be used that aren't being used.
The question was, has to do with diagnosing coronary artery disease. I showed the tests that were there, and the invasive test of the cardiac catheterization actually requires a catheter be placed in the coronary arteries and have a picture made. The question had to do with non-invasive testing, and specifically for MRI. That, I believe, is going to be the future of all heart imaging. Echocardiography is very good, but I think that the MRI will give us many more answers. It'll be able to visualize the coronary arteries, as you're asking about. It'll also be able to visualize valves. It can look at flow to the heart muscle. It can look at the wall motion, the volume of the heart, in many cases diagnose congenital heart disease. We're just now beginning to use that clinically. here at Stanford. And I'll have to say that one of the great and exciting things about this institute is this is a prime example of how working with the electrical engineering department at Stanford, radiologists and cardiologists in particular, were able to bring this field along. So Stanford is one of the leaders. It's not widely used clinically by most physicians, so that if you have coronary artery disease or a positive stress test, you're probably going to get a cardiac catheterization, because if a stent can be placed, then they can do it right there. But it's something that I think you should ask about. If someone tells you need a cardiac catheterization, ask, could I have an MRI? There's certainly, I got a question about this the other night, and that is something that's coming. I'll just say that that the heart scans with CT scans, there are many shopping centers or strip malls that have CT scanners that you can run in as you're going to the grocery store and find out if you have heart disease. Steve Fortman said the other night in his lecture, the studies really have not proven that to be a very good screening tool. It can show if you have calcium, but not really as good as, say, MRI is going to be.
Okay, so the question was, the PEPI, HERS, and WHI were using pharmaceutical estrogen. In fact, they were all using conjugated equine estrogen, or Premarin. PEPI actually did also use micronized progesterone, so that's equal to natural progestin, but otherwise it was using medroxyprogesterone acetate. The question she had is, have we looked at any of the bioidentical estrogens and progestins, which are estrogens and progestins that are essentially identical to the ones that we actually make, because Premarin, for instance, is a horse product. It's not a human product. And the answer is we have very small studies in this. We don't have anything of this magnitude. We don't have any way of saying that they are safer or that they are as bad. And so it's very important to realize that that's true. We didn't study those, but I think it's still worth saying that most of our belief that hormones prevented heart disease came from Premarin, and so the basis of the belief was wrong to begin with. And I think the bioidenticals still play a nice role for menopausal management, but I personally think that hormones are for menopausal management and not for disease prevention. Women are gaining weight, they're inactive, there's years of abuse of a body, so that by the time you're 55, you're getting to that. Maybe your question relates to whether the 55-year-old woman versus the 45-year-old man, but there are so many possible explanations for that to just come down to saying we should be on hormones to prevent heart disease. I personally believe that we've tested that theory and that preventing heart disease, really we need to get back to it's not necessarily a pill. Now statins might be a pill, but we certainly don't have, I think we need to do diet, exercise, and weight control.
The question was, are there any physicians here at Stanford that specialize in cardiovascular care of women? The answer to that is there's some very good women cardiologists, I'll say that. And they do have an interest in women's cardiovascular health. I think that the prevention group, Steve Fortman and that group, certainly are a group that are looking over prevention for both genders. But this is what I alluded to, and one of the core missions of the Institute is to bring a cardiovascular women's clinic to Stanford. Because as I go around the country, and I've been looking at this because I'd like to recruit a very passionate woman about this issue to Stanford to start this effort. But there's no one place you can look up on a website and go to, and as you know, or come to a clinic. So I think that's something that is foremost in our minds at the Institute. The question has to do with statins, lipid-lowering drugs.
Is lipid-lowering drugs. And there's something called the National Cholesterol Education Program, and they have adult treatment guidelines. And they have recently come out with much more aggressive guidelines for LDL lowering. And part of that is because we now have a drug that's very effective and tested in trials. So you can be a little bit more aggressive that way. And it does have very clear jump points where if you've got family history, if you've got certain kinds of risk factors, the metabolic syndrome is a new part of this, that you're going to become much more aggressive. And so where we used to say you want your LDL cholesterol below 130, we now have it where there's a whole bunch of people that the goal is to get it below 100, and there's even now a group of people that the goal is to get it below 70. So the best thing to do is to go to a preventive cardiology clinic and get some consultation about that.
The question is, patients that have cardiovascular disease, particularly coronary artery disease, and I think it goes across the board for peripheral vascular disease and maybe even stroke, often have normal or not elevated cholesterol levels. So some comment about that. You probably know as much about it as anyone.
It's actually a fascinating question, and Steve Fortman, who's the director of the Stanford Prevention Research Center, is doing a big study now with some other folks at Stanford looking at the genetics of that, trying to understand what is the genetics of people who have no risk factors or very little risk factors, not just cholesterol but blood pressure and all the other ones we mentioned. And so there is a lot of interest in what makes that happen, but we don't have the answers yet. Fortunately, we have a lot of new technology in the world of molecular biology and genomics to go after that. But it's actually true what you say. The majority of people who get these things don't have these high risk factors. And it's true for women with breast cancer, too. I do a lot of work with breast cancer survivors, and the vast majority of them have none of the risk factors. So we have a long ways to go.
I think also to add to that, there are other things besides just cholesterol. You know, there are triglyceride levels, homocysteine, LP(a), a lot of other things that can be tested. And I would say echo Marcia's comments about a preventative cardiology clinic, because they have the capability and the expertise to measure all of these things if you have a very strong family history. The question is, taking Lipitor, is there any consequence with your LDL going too low? So my response is I'm not aware of anything that can is too low.
In fact, you know, people often say that the real goal would be to be below 40, which I don't know anyone who's below 40, and that's based on, you know, what are our arteries really supposed to be handling. So no one has ever written anything about concerns about LDL being too low, as far as I know. So
it goes along with you can never be too rich or too slim. You know? The question is, you had a stent 4 months ago. What's the probability it'll stay open a year? It's either 0 or 100%. But you know, this is. You know, without knowing more about the details, was it a drug-eluting stent? Where was it placed? I mean, I don't know. I can't tell you. I would say that overall, the restenosis, the scarring, the blocking in the stents, generally were about 20%, 20 to 25% before this new generation of drug-eluting stents. And sounds like if you've had bypass surgery and another stent that fails, I bet you've got a drug-eluting stent. And the restenosis rates, generally speaking, across the board, are down in the single digits, which is a major advance.
Okay, the question was, what alternative therapies are we recommending for women who have hot flushes but don't want to go on hormones, including bioidentical hormones, I assume. Okay, so there are a lot of complementary alternatives that people have tried. So there's soy and dong quai and black cohosh. The reality is none of them have actually have proven to be effective in randomized controlled trials. Some individuals report that they're fine. We actually have, I have a talk on menopause, which isn't really the theme of the night, but you know, we start out with lifestyle, and some very simple things as wear layered clothing, drink a lot of ice water, don't eat hot spicy foods, don't drink alcohol. All of those things you have to, or coffee, those things will increase it. So you have to get down to what are the things that really precipitate the events. For some people, you can try all kinds of things and they're still going to have really severe hot flushes, which is why none of us that ever talk about this from the Women's Health Initiative would ever say women shouldn't take hormones, because there is a place for hormones. You might want to try other kinds of hormones, including bioidentical. You might want to try soy. But the bottom line is, waiting it out is probably a reasonable thing to give it a go, to try, if you can. Because what we're very clear on is if you go on a hormone and especially the high doses that we were giving women for the last decade, you actually get to the point where everything in your system is geared up to needing that drug. It's almost an addiction, so that when you withdraw it, many women had much more severe problems when they came off those pills than they ever had before they went into it. So we're trying to encourage people, if you can, just do your best to go on a lowest dose possible for the shortest period possible and just let your body get through menopause.
So the question is, you have a high LDL, but also a high HDL. I don't know if you have an answer for the balancing.
Well, the Framingham study was really the leader in talking about ratios. And so most of you probably have heard about your HDL to total cholesterol or HDL-LDL ratio. And it is true that if your HDL is high enough, you can get by with higher LDLs. But at some point, the LDL in and of itself is still going to need to be managed. So when we talk about a high HDL, we actually, I had it on a slide, but I did point out, if your HDL is above 60, you actually get to have a negative risk factor. Now, most of us want that one to take care of the fact that we're going to get to be 55 or we are 55. And so you want to hold out for the age factor, that's where you're going to use that risk factor. But there is value in the ratio, but at some point you still have to focus on that LDL. Her point was the specific medication that one doctor said versus the other. Something that's really true, and I think we've already alluded to it before, is that new things are coming along that take a little bit of time to spread on through. Some of them come right out of the woodwork and everybody jumps on them, and then you find out they're not so good. So it's kind of a challenge to figure out when do you jump on that hot study and when do you just say, you know, I need to go with my clinical experience. So that's something that physicians don't always agree on what they're doing.
So in your particular case, you bring up another good point, side effects of statins that we really didn't talk a lot about, and liver problems. So, you know, it sounds like you need a third opinion to adjudicate this, but I would say go with what your cardiologist is telling you, because if you have liver problems, that's really a contraindication to statins.
So her question is, what about elevating your HDL? And she made the point that exercise. Most of those studies actually were done here at Stanford by Peter Wood and myself, so we know this data very well. Weight control is probably more important than exercise for getting your HDL to come up. But with people that have really low HDL, we don't have very good evidence that these lifestyles will really take care of that problem. So it works for kind of the middle range, but not for really low. There is a drug that came out called gemfibrozil, which there was a trial that came out a few years ago that showed that gemfibrozil, which very selectively raises HDL and lowers triglycerides, for people with that particular problem, it was effective in preventing heart disease. So there's at least one drug now that does that, and there are some other drugs that focus on HDL and LDL for people with low levels. But, you know, with everything, it's kind of like there's optimal levels, and you may be fine with the level that you have. So the goal isn't just to get this higher and this lower necessarily.
And one other point about that, some of the statins can give a modest increase to the HDL and niacin. I don't know if you have any comments about niacin. That's also been touted as something that could increase your HDL, but there are some side effects to that.
Okay, so she asked about quality of life, and she actually asked a lot of questions about, are they doing the head-to-head comparisons of hormones to Fosamax to these other things that have other side effects. And the first thing I'll say is that you almost never see head-to-head comparisons between drugs, because that's a real issue. In PEPI, we had to go through tremendous effort to get 3 different pharmaceutical companies to help us study the micronized progesterone, the medroxyprogesterone, and this and that. So there are very few head-to-head comparisons. We did publish the quality of life data from the Women's Health Initiative. Now that was a select group of women who didn't have severe symptoms. So when you start to talk about the quality of life issues, there are a lot of behavioral scientists that are interested in all those side effects and all those quality of life issues. But we really don't have the data to say that this is really, a woman is much happier on this than on that, than on this, than on that. So the answer, unfortunately, is no. She asked, what about aspirin? You went specifically after metabolic syndrome. I don't know that anyone's done anything specifically about aspirin and metabolic syndrome. I will say that the best evidence for aspirin relates to people who have heart disease, that it's very effective in preventing, or it has been shown to be effective in preventing the next event. But we don't have as good data, particularly in women, for primary prevention. So there is data in men for primary prevention, but we don't really have that piece of solid evidence for women for primary prevention. Do you want to? You know, I'm a big believer of evidence-based medicine, so even though I'm not doing medicine, I feel that it would be nice to get that study before you before you start recommending that in public. But maybe...
No, I would agree with that, although, you know, there are many people who take aspirin, and the studies that have been done show that probably a baby aspirin is okay, not a baby aspirin at 81 milligrams.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.